Mark, I think yeah, if you can mute, that would be great. Perfect. All right. I think we're good to go now. Okay, great. Sorry about that. So let's start again. So my name is Kamran Mirza, and I am an associate professor of pathology at Loyola University Health System in the Chicagoland area. And thank you very much for this invitation, by this Facebook Medical Journal Club. I'm happy to be here. Today we'll be discussing the pathologic manifestations of COVID-19. If you are ever interested in pathology specifically, you can follow my Twitter account. It's KMIRZA. We do a lot of professional pathology conversations. I don't think I could move even one step forward without acknowledging Dr. Sanjay Mukhopadhyay, who is the Director of Pulmonary Pathology at Cleveland Clinic. You can follow him as well at SM Lungpath Guy on Twitter. The reason for this acknowledgement is because on a day-to-day level, I'm a hematopathologist. So my work day-to-day is dealing with blood, bone marrow, spleen, lymph nodes, etc. And so much of the data that I'll be showing you is actually information that Dr. Mukhopadhyay has graciously lent me, and that pertains to the autopsy and to the lung findings in COVID-19. So thank you to Dr. Mukhopadhyay, and all his slides will be credited with his name at the bottom. All right, so specifically today, I wanted to talk about morphologic manifestation. So what do we see under a microscope, or what do we take a look at when we're dealing with cases of COVID-19 pathology? And this actually goes hand in hand in the laboratory with obviously our understanding of the PCR of the disease as well. And naturally, none of the people in the audience will be any type of stranger to this information. Naturally, the total confirmed deaths right now, despite the fact that there are numerous challenges in the attribution to the cause of death, whether somebody is dying of COVID-19 or not, still the number of total confirmed deaths is obviously exponentially increasing. And in the laboratory, we had initially struggled a little bit because there's a certain amount of misunderstanding about how testing is actually done for humans. And this has been one of our struggles because every kind individual was offering to be able to help us with their PCR machine from their research labs, but that's not how human testing works, right? So whenever anyone in this audience orders a test for their patients, it goes to obviously a CLIA certified laboratory where there's numerous checks and balances and regulation, from the environment to the machine to the personnel. Everything has to be very tightly regulated. And so COVID-19 and the laboratory kind of had this interesting start where initially, the few centers that started rolling out the test were those centers that were able to get, positive control samples and negative control samples and, had the right personnel in place. So when you think of the laboratory and COVID-19, naturally, you obviously will consider viral PCR, right? And so I won't be talking about the antigen and antibody testing or the viral PCR, but suffice it to say that whenever you're interpreting a test which is from the clinical lab, every single test has its sensitivity and specificity, and the people in your laboratories, like if for example you're doing a saliva based test or if you're doing a nasopharyngeal swab, the testing in your lab has actually been validated for that one particular sample, right? So just because a test is available doesn't mean that all of a sudden you can switch to a new type of test without the lab actually having to do a significant number of procedures to make sure that the clinical results that you're being given, in an actionable form are correct, right? And so the laboratory has obviously been instrumental in all of these things, but there are also some non-PCR or antigen antibody type of findings, which we will be talking about today. And those could be serologic markers. So for example, data from the CBC or even other studies that has been shown to kind of correlate with the fact that somebody might have COVID-19. And then specifically what I'll be talking about today will be the morphology changes, right? So are there morphologic changes in the peripheral blood of these patients, or if there are any changes in the tissues or in the organs of this, which we can kind of look at histologically. Towards the end, we'll be taking some questions. All right, so let's start with the peripheral blood. The peripheral blood and the CBC in general are probably the most powerful tools that we have in a hospital system. It's such a simple biopsy, and it can tell you so many things, right? And so the morphologic anomalies of circulating red blood cells have actually been studied. The good news is that the study has been helpful in us trying to navigate this disease a little bit, but the bad news is that all of these findings are very non-specific. So would I look at a peripheral blood smear and definitively diagnose COVID-19? No, right? Would you look at it and do it? No, right? So the idea is that any virus that affects the human body can have some viral cytopathic effect, right? So there are some changes that are seen, which could either be due to the fact that the virus has infected a particular cell and has changed that cell, or it could be because of the fact that the cells around it are reacting to it. So those are the features that we consider. And here in these multiple kind of panels, what we're seeing is numerous changes in the neutrophils and numerous changes in the in the lymphocyte populations that are seen in patients, different blood films from COVID-19 patients. So here in A, B, C, and D, what we're seeing is that these are different types of neutrophils. A normal neutrophil looks pretty much similar, a little bit similar to the one shown in D. So you can see that the ones in A are not as segmented as normal, especially in the one in B. You can see that there's no nuclear segmentation at all. Normally, a neutrophil will have different types of segments. That's why it's called polymorphonuclear, right? And similarly here, you can see that the neutrophil nucleus is uni kind of lobated. It's just round, and there's a ton of significant granulation. E and F are also showing you some myelocytes or immature cells, right, which would be constitute a left shift. And none of these findings in the granulocytic cells would be specific for COVID-19, but this is within the range of what you can actually see. You can also start seeing even more immature cells. Here you can see that the nucleus in this particular cell is very immature appearing. You can see how light in color it is compared to this neutrophil that has condensed chromatin. And similarly, you can see apoptotic figures and kind of really large giant platelets with maculations as well. So this is a spectrum of findings, but particularly what has been shown have been two things. One is a feature of a lymphocyte, which people have started calling covicytes. And here you can see this is Dr. Hermelin on Twitter, and this is she is a blood banker, a fantastic individual, very important to follow her if you're interested in blood banking on Twitter. And here you can see that in her experience, every peripheral blood smear she has seen in patients who have COVID-19 have these covicytes, and what she describes them as are large and atypical lymphocytes with an irregular kind of nuclear border. So you can see that there's a certain amount of irregularity here, and then you can see a deep blue cytoplasm and a little bit of a white clearing. In many ways, actually, this is what we call a plasmacytoid lymphocyte. So you know that lymphocytes are obviously one of the cells that can terminally differentiate into plasma cells. And plasma cells have this appearance where you have an eccentric nucleus with a clock face chromatin. And typically those cells also start displaying this white HOF, which is paranuclear. So these, kind of reactive appearing lymphocytes have been a common feature of peripheral blood smears with COVID-19. Also, what we see is that in the right side here, I'm showing you peroxidase findings in patients, for example. So you know that in all neutrophils have a cardinal enzyme called myeloperoxidase, and myeloperoxidase in general. Here you can see that in the purple signals are the neutrophils, and you can see that the green signals here are monocytes. And ultimately, what's happening here is that you can see that there's a slight decrease in the myeloperoxidase in the neutrophilic population because of the fact that these are kind of abnormal neutrophils. But again, these are not features that one would use to definitively diagnose it. I did want you to see the spectrum of lymphocytes that we can actually normally see. Here is the normal mature lymphocyte. So for those of you who've looked at peripheral blood smears, you can typically, this is what you look for, very thin rim of cytoplasm and a high NC ratio. And then there's a spectrum of reactive changes that can occur. Typically, the ones here that I'm showing you with this very skirty cytoplasm that is seen kind of kissing the red cells or embracing them. These are downy type 2 cells, which you typically see in viral infections, such as infectious mononucleosis because of EBV infection, right? And so this is one type of lymphocyte response to virus. The other type is basically where you start seeing, again, similar to what we were showing, what I showed you in Dr. Hermelin's tweet. Here you can see that there's an irregularity of the nucleus, a little bit of chromatin clumping here, and you can see this white HOF again, right? So this becomes a little bit more plasmacytoid, and plasma cells have a more pushed in to the side nucleus here. So within the spectrum of lymphocyte maturation, you can see that viral infections can have morphologic changes of lymphocytes, and COVID-19 is no different. However, beyond the morphology of the COVID-19 cells, what we're also finding is that this lymphocyte subsets are also being altered in COVID-19 patients who have pneumonia. So this is a study that was published from Wuhan, China. And here you can see that there are significant numbers of differences here. So there are two populations that they're comparing. One is a COVID pneumonia population, which is CP, and the dots are red. And the other one is a healthy control population, which is HC, and the dots are blue. So they're looking at the total number of lymphocytes. They're looking at the CD4 positive cells. They're looking at the CD3 positive cells. They're looking at the CD4 CD8 ratio, the number of B cells, which they're measuring by CD19, and also the number of CD56 positive NK cells. And here you can see that the three asterisks can mean that the p-value is less than 0.001 and is significant. And any value that is not statistically significant, they have denoted by an NS for not significant. So here we see that peripheral lymphocyte subsets are definitely altered. One, if you think of all total lymphocytes, healthy controls have a higher number of total lymphocytes, and this is statistically significant compared to a lymphopenia that is seen in patients with COVID pneumonia. This lymphopenia is also reflective in the fact that both the CD4 positive and the CD8 positive cells are higher in the normal healthy controls, and they are statistically significantly lower in the COVID pneumonia patients. The difference between the CD4 CD8 ratio in general actually does not change, but the absolute number of those cells does go down. So the CD4 CD8 ratio between these two populations is not statistically significantly different. There is another feature of the B cells. Here you can see that the B cells are statistically significantly more in the normal controls, and there are less in the COVID pneumonia patients. And even in CD56, although this looks borderline, this was also statistically significant, where NK cells are more in healthy controls and less in COVID pneumonia patients. So not only are the morphologic manifestations of COVID pneumonia being shown in the lymphocytes and how they look, but also we're seeing that the subset lymphocytes, which many of us kind of order for HIV positive patients, etc., the lymphocyte subsets show that there is a marked lymphopenia in these patients. Here, basically, this is the same. I think it just looked a little different. So the summary of diagnostic and prognostic value of hemocytometry has been published also here in a study from the Netherlands. And here what they conclude, if anybody wants to look at this article, you are absolutely free to do so. However, I just wanted to summarize that the hemocytometric changes they conclude, especially the presence of lymphopenia, right, and an elevated neutrophil lymphocyte ratio in patients infected with SARS-CoV-2 virus may assist clinicians in diagnosing and predicting disease progression outcome of COVID-19. And here they show that the worse the lymphopenia is, the worse the patient does. And if there's an elevation in the neutrophil to lymphocyte ratio, right, which also is indicative of the fact that there are more neutrophils compared to lymphocytes, and that ratio keeps getting elevated. Both of those actually are both not necessarily diagnostic, but they're definitely of prognostic value in these cases. All right, so if you bear with me, I'm going to show you a little video, which is a few minutes. We'll probably cut it a little bit short before we go on to talking about the lung manifestations.
You're looking at a virtual reality image of a coronavirus patient at George Washington Hospital in Washington, D.C. The patient is a generally healthy 59-year-old man with high blood pressure. Just days before this image was created, he was asymptomatic. But now, those green areas show where the infection has damaged tissue in the lungs. For many, COVID-19 will be mild, but for others, it's deadly. This video is about the latter path, how the virus kills. We'll start in China. 191 confirmed COVID-19 patients were in a hospital in Wuhan. 54 died. Of those 54, 50 had a condition known as ARDS. Acute respiratory distress syndrome is a condition that stops oxygen from reaching the organs.
You have air hunger.
It means that they can't breathe.
There's a very strong correlation between the people who develop ARDS and the people who die.
ARDS is not unique to COVID-19.
It's such a long list of causes. Infection, people with HIV/AIDS, if you get into a big motor vehicle accident and sustain multiple injuries to multiple organs, that causes ARDS. SARS and MERS. Now, things that you inhale and that can be toxic can cause ARDS. Household bleach, war gases, mustard gas and phosgene. So the people who vaped THC that was contaminated with vitamin E acetate, and those patients were also developing ARDS.
Here's what's actually happening when you get ARDS. When we breathe in air, oxygen goes down our windpipe and fills the lungs. Specifically, the small air sacs at the end of the lungs are the key to air exchange in the body.
So that's why nature has created, or evolution has created, this the barrier is so thin, it's just a few micrometers in size. So the oxygen has to go through just a little bit of collagen, the cell that lines the alveolus, into the red blood cell. Once it gets into the red blood cell, then the blood takes it back into the heart, and from there to the rest of the body.
And this is the key to understanding why COVID-19 is killing people.
That entire wall of the air sac gets damaged by the virus. Think of it like a thick layer of paint on the inside of the walls of a room, or a thick layer of mold on the walls on the inside of the room. That's what it looks like.
As that wall becomes thicker, oxygen can no longer pass into the bloodstream, and your organs begin to suffocate. So if you are sick, you might be asking yourself, am I in the mild path or the serious path? A good indication is whether you have severe shortness of breath and for how long. Those are indications the virus has progressed lower into the lungs. One small study of hospitalized patients in China found that 0 to 2 days after development of symptoms, chest scans were coming back normal for more than half of patients. Keep in mind, these are patients that were sick enough to be in the hospital. But within 3 to 5 days after symptoms started, that flipped, and 91% of hospitalized patients had significant respiratory issues.
As you progress beyond that 7 to 10 days stage, that's when ARDS seems to be developing. And once it develops rapidly fast compared to ARDS developing from, let's say, another cause. And these patients seem to be doing much worse over a relatively faster period of time.
Many people have mild or even no symptoms with the virus, but the longer COVID-19 affects your lungs, the higher the risk of serious respiratory issues.
And the longer you're on a ventilator, the less likelihood you will come off the ventilator. That is the blunt truth of this situation.
When I saw this on our first patient, and you see the extent of the damage and how it affects both lungs and various parts of the lungs. And it's much more striking, even for somebody who's been in practice for almost 20 years.
And that's what happened to this patient.
Just about 1 week after being at our hospital, unfortunately, he passed away. Really, my goal of trying to get this out into the public is so that they understand the severity of the problem that we're seeing, and why the social distancing and the flatten the curve and every other hashtag that's come up in the past couple weeks is just so important, is because this is a community-wide problem, it's a global problem, and it's going to take a community solution, right? Everybody has a role to play, and if you're not in the healthcare field right now, your role is to stay home, right? Because again, the virus doesn't move on its own, people move, people transmit the virus.
And the longer you're on a ventilator, the less likely.
So, most of you obviously are no stranger again to that type of information, but it was very important because much of our conversation now is towards the middle half of this talk will be regarding the lung. So acute respiratory distress syndrome is definitely associated with a risk of death that is higher. And the problem is that in many cases we can't predict which patients will do worse or which will do better, because we can't predict who will get ARDS. But in this paper that was published in the Lancet, again, this is from China, from Wuhan, China, they looked at 191 patients, and of those, you can see that 59 patients, which is 31% of them had ARDS, right? And then of those, if you think about the non-survivors, the patients who actually passed away, 93% of them actually had ARDS, while only 7 of them, had ARDS in those that survived. And so the link between survival and acute respiratory distress syndrome is extremely, extremely high. And It brings basically the definition of ARDS is that obviously it's a clinical syndrome, right? Acute respiratory distress syndrome. The pathologic manifestations of this are known as diffuse alveolar damage, and I'll show you those. But the acute onset, which is typically within 1 week of the known clinical insult, there's respiratory failure that's not explained by heart failure or fluid overload, right? And this is for ARDS that could be because of any cause. Typically, the outcome is because of hypoxia, and you have bilateral lung opacities on chest imaging. So you can see here, I'm not a radiologist, but even I can see the comparison between the normal chest on the right and the abnormal ARDS whiteout chest on the left. And as Dr. Mukhopadhyay, who was actually in the video speaking about the different causes of ARDS, has mentioned that this is almost like the end game result of a significant number of etiologies, right? So it could be shock, it could be sepsis, it could be inhalants, it could be toxins, it could be aspiration pneumonia, it could be radiation, and like basically the lung has only a few ways that it can actually manifest injury, right? And so it could either be pulmonary edema, it could be pulmonary fibrosis, it could be scarring, and it could be ARDS, right? So typically that's what we think of. In the acute setting, it will be acute respiratory distress syndrome. And I really like how he described this idea of being in a room and, having mold or like thick paint around it, right? Because it's a physical barrier or an obstruction to the oxygenation, and I'll show you some pictures of this as well. So obviously you have a large chunk of patients who have COVID-19, and then you have a large chunk of patients who have ARDS, but this red arrow is pointing to that overlap where in symptomatic patients in COVID-19, ARDS will be one of those linkages. So here, this is direct evidence or proof that patients who have coronavirus, pneumonia, they actually have coronavirus infecting the cells. And so here we're using a technique called chromogenic in situ hybridization. In this picture is courtesy of Dr. Chris Larson, and the slide credit is Dr. Mukhopadhyay. You can see here that the lung parenchyma still looks pink and blue, the normal parenchyma in the background, but the orange arrows are pointing towards these brown dots. These brown dots are pneumocytes that are basically being stained specially by this chromogenic assay. And the way this works is that, typically you think of special stains as an antigen antibody reaction. But in this particular case, what we have is that the probe that we're using to identify the cells is a probe against the RNA portion of the SARS-CoV-2 coronavirus. And so here you can see that only those cells will become positive that actually are infected with this RNA virus, and we are detecting it because the RNA is actually present. And so the color of positivity is brown, and the background coloration is just the normal coloration of the of an H&E kind of stain. So here you can see that the pneumocytes are actually being infected, and this is a contrasting slide of diffuse alveolar damage on the left and normal lung on the right. So we'll look at the normal lung. Here you can see that the green arrows are showing you the delicate, beautiful alveolar septae. You can see the alveolar walls, and there are some red blood cells. Like these are very, very thin capillaries where obviously the epithelium and endothelium are opposed to one another, and there's literally a very tiny basement membrane between them. And this is what Dr. Mukhopadhyay was talking about, the efficiency of the lung oxygen exchange. Now you can see on the left side, the diffuse alveolar damage are these pink, thick linings around the wall, and like you can see that there's an interstitial widening as well. And here the same thin delicate septal membrane, alveolar membrane, has actually become so thick and it has diffuse alveolar damage. So diffuse alveolar damage, or DAD, is what the histologic reports will basically show you in these patients who actually have acute respiratory distress syndrome. And you can see here that in the later phase, you can start seeing fibrosis occur as well. But imagine the oxygenation against this, this pink kind of thick material, which is just acellular. And I kind of think of it as like, if let's say an alveolus gets full of fluid and then all the fluid is drained and only the junk is left over, and that junk sticks to the alveolar lining, and that is basically what causes the lack of oxygenation and hypoxemia in these patients. So it results in sudden severe injury to the lung, and when ARDS is developing, oxygen levels will drop in patients, and ventilators are required obviously to keep these patients alive. So Dr. Mukhopadhyay was also one of the senior authors in the first COVID-19 autopsy series in the United States that was done outside of China. Here is the paper, and you can see that Dr. Barton is the first author, and this is an autopsy series from Oklahoma. And this is effectively talks about two patients and their autopsy findings. So I wanted to pause here for a little while and kind of address this idea of autopsy in the coronavirus, COVID-19 patient. Many institutions have the ability to perform autopsies, and many of them are academic centers or non-academic centers. However, initially, especially when we were trying to better understand what the mechanism of spread of coronavirus is, many places don't actually have the physical barrier. They have the physical barriers in the PPE when we do autopsy. However, you need to have a certain regulation within the environment, like a negative pressure control room, etc. And so many places, for example, when they perform autopsies for patients with Creutzfeldt-Jakob disease or any other prion disease, they need a similar kind of environment. And so a lot of institutions initially were very limited in doing their autopsies if they did not have the correct autopsy suite or morgue available to them. However, the autopsy studies have been very instrumental in understanding the pathogenic manifestations of COVID-19. And so here you can see the obliteration in the lungs of this patient, who was a 77-year-old man. He presented with a history of fever and chills for around 6 days, and his past medical history was of hypertension and a remote splenectomy. He was never tested for COVID-19, and he went into arrest en route to the hospital. And here you take a look at his lungs, and you can see that the green arrows are showing you little bits of kind of pulmonary congestion with those red blood cells clumping, and the white arrows that are kind of difficult to see. But these white arrows are showing you the hyaline membranes, the thick diffuse alveolar damage that is effectively all over this patient's lungs. There is also a significant amount of inflammation. Here you're seeing that this is a very low power image, and you can see the airways here because of the cartilage that's present, and you can see that there's thickening within this inner layer, and that thickening is because of lymphocyte-based inflammation. You can see here that within the vessels there's congestion with lots of red blood cells, and here what the red circles are showing you are lymphocytes that are basically, this is the epithelium right here, the pseudostratified respiratory kind of ciliated epithelium. And in the submucosal subepithelial space, you can see that there is an infiltrate of lymphocytes, right? This mononuclear infiltrate is indicative of like a chronic inflammatory process. So here you can again see the interstitial inflammation. It is being pointed out by the red arrows here, and the red arrows are showing you these lymphocytes, right? So these are not neutrophils, these are lymphocytes. And here this is also a feature that was presented in this autopsy series. When we take a look at what type of lymphocytes they are, right? And so we typically think of T cells, which are CD3 positive. And so you can see here that this is an immunohistochemical stain where the dark brown dots are the CD3 expressing T cells. So this is an antigen antibody reaction that is highlighting the type of cluster of differentiation marker that the cells are expressing on their surface. Typically, we think of this as a ratio of CD4 to CD8 cells, where CD4 should be more compared to the CD8 cytotoxic cells. And here we can see that of the lymphocytes that are present, in general, there's lymphopenia, but of the lymphocytes that are present, there is more CD8 positive T cells compared to CD4 positive T cells. In the same article, they also discussed another patient, 42-year-old man, with a history of abdominal pain that also was followed by respiratory symptoms. He had a history of myotonic dystrophy. Again, he was never pre-mortem, like tested for COVID-19, and died a few hours later in the hospital. Again, he had acute bronchopneumonia. This is a very different process. You can see here that instead of the normal lymphocytic, not normal, but the lymphocytic response that we saw in the previous patient, you can see here that there are tons of neutrophils and lots of hemorrhage, and like this whole lung field has been obliterated. And you can see it's because of the fact that the patient had actually aspirated a significant number of probably food, and that had caused like a reaction, which was a bronchopneumonia. After this first United States study, like the first English one in the peer-reviewed literature, there were a significant number of other studies that came out of autopsies. And so Mentor published 21 cases, followed very closely by Wishman, who presented 12 cases, and Lax presented 11 cases. And this was all in May 2020. And the significant features or the importance of these autopsies in this pandemic is obviously, as our understanding of this disease was getting better and better, the post-mortem examination was very helpful in revealing what the patient's causes of death were, right? And so basically, if you think about it, the first study was from Basel in Switzerland, where autopsies were done in 20% of hospital deaths. And there they showed that post-mortem examination of COVID-19 patients showed diffuse alveolar damage with severe capillary congestion and variegated findings of lungs and other organs suggestive of vascular dysfunction, which basically were very similar to the findings that were reported earlier in the Mukhopadhyay study. In Hamburg in Germany, where they have mandatory autopsies, the autopsy findings were of venous thromboembolism, which again is a very important feature of this disease, as we're discovering more and more. And in Graz, Austria, 11 of the 48 COVID-19 decedents were autopsied, and they showed pulmonary arterial thrombosis in those patients that had a fatal outcome, and that was a prospective single-center clinical pathologic case series. But again, here, if you take a look, you can see that in these cases, while the alveolar septa is actually still pretty thin, you can see that there is these pink hyaline membranes, which are indicative of the diffuse alveolar damage. So then one wonders if diffuse alveolar damage by itself would be, simply kind of very specific to COVID-19. But like we've discussed before, diffuse alveolar damage is the end game of a significant number of insults that can happen in patients. And you can see here that the contrast between the diffuse alveolar damage that is being seen now in this coronavirus COVID-19 pandemic compared to the diffuse alveolar damage that was also seen in patients who had H1N1 in 2009. And so, these are similar kind of findings as far as diffuse alveolar damage is concerned. Also, if you think about the bronchopneumonia, which was the second feature that was shown in our first case series that we discussed, here you are looking at the same three cases by Mentor, Wishman, and Lax, and we find that bronchopneumonia in the first case series was seen diffusely in 6 and focally in 4 patients' lungs. In the second study in the middle, you can see that focal bronchopneumonia was actually seen in a third of the patients, and bronchopneumonia was seen in 6 patients in the last study, which were ranged from being focal to confluent. And so the autopsy findings in the lungs basically kind of talk about 3 major things, right? Diffuse alveolar damage, pulmonary congestion. You can also think of thrombi, and also focal bronchopneumonia. So here's the last feature, the thrombosis that is common in specifically fatal COVID-19 infection. This thrombosis can be seen in alveolar capillaries. These alveolar capillary microthrombi were seen in 5 of 11 patients in the first study published in Histopathology. In the second study, there were 7 to 12 patients. 7 out of the 12 patients had DVT, actually, with a massive PE in a third of the cases. And thrombosis was seen in all 11 cases that were published in the last study by Lax. And so that is the main feature, again, that is extremely, extremely important. Here you can see gross organ findings. You can see that there's basically bits and pieces of the lung which have this kind of variegated pattern. You can see that there's thrombosis occurring with, like here, the thrombi. These are the pre-mortem thrombi, which you can kind of tell histologically. And here you can see that this is the thrombosis that is being pointed out histologically by the red arrows. And, the one way that you can tell the difference between a pre-mortem and a post-mortem clot is when you consider these sequential lines of a kind of plasma and cells, and these are called lines of Zahn. And this is indicative of the fact that there has been pre-mortem clotting, and so thrombosis becomes an important factor in these cases. So those microthrombi that was seen in the pulmonary vasculature here, this is again from the Mentor study, which was published in Histopathology. You can see that the red arrows are showing you fibrin clots. These are vessels within the lung that have been kind of filled up with this fibrinous material, which are the fibrin microthrombi. If you actually use an immunohistochemical stain against fibrin, you can see here that all of the brown that is within the capillaries is showing you the significant microthrombi that are stuck in the thin capillaries and these alveolar septae. So here you don't necessarily see any evidence of diffuse alveolar damage because there are no thick membranes. However, within those thin alveolar capillaries, what we're seeing is we're seeing lots of brown staining, and that brown staining is the stain for fibrin, and this is because these are all fibrin microthrombi. You can also see microthrombi in other organs. This is from the kidney. You can see a glomerulus, right, with the Bowman's capsule, and you can see inside here that there is a significant amount of this thing, this really dark kind of pink-red stain. This is not an H&E stain. This is a different type of stain, so the coloration is a little different. But what is important to understand is that there are microthrombi that are filling in the glomerular capillaries. This was taken from the Mentor study again. The picture is courtesy of Dr. Alexander Zankov. So the question then arises whether thrombi in diffuse alveolar damage are unique to COVID-19, and ultimately the H1N1 influenza study here that was published in the AJCP also talked about the fact that microscopic thrombi within pulmonary arterial system have been described in association with influenza and diffuse alveolar damage, and that the number, size, and peripheral location of the thrombi observed in this one study in AJCP may be unique to the novel H1N1 influenza virus infection. However, in general, the presence of thrombi, unless like proper studies are done looking at their location or looking at their findings, would not be very specific to COVID-19 infection, because, for example, here, these are the same microthrombi that we've been looking at along with some diffuse alveolar damage, but you can see these microthrombi were from H1N1 and not from COVID-19. So we've talked about, we didn't talk about PCR specifically, but we've talked about the CBC, we've talked about lymphopenia, the neutrophil to lymphocyte ratio, we've talked about lymphocyte subsets, we've talked about the major damage being in the lung and being ARDS, and also the features of microthrombi and other changes within the lung, including bronchopneumonia. So what about other organs? So numerous anecdotal studies are coming out now, and anecdotal data about patients, having a variety of symptoms. For example, my wife is a pulmonary critical care physician, and she takes care, she's on the front lines taking care of patients in, COVID-19 ICUs. And, and many of the patients she's seeing now, like, are endorsing things such as, memory loss, for example, which is not attributable to anything else. And so I think it's probably really early to tell what the long-term sequelae will be. But in the heart, there have been associations with myocarditis, although this is uncommon. There are patients who have shown up with hypertrophy and also with senile type amyloidosis. Here you can see that there is a myocarditis in the image, which is taken from Wishman's study in histopathology. And here you can see that this is the lymphocytic myocarditis, because again, this is a mononuclear infiltrate that's very specific, and it's lymphocytes. And so the heart has been affected and has shown some degree of damage in cases with some myocarditis. Kidneys have been studied to show acute tubular injury, but then the question remains whether it is actually directly caused by the virus or not. And viral particles have been reported in the tubular epithelium of patients. And so the question, and here you have to be very careful as to whether these are truly viral particles or whether we're reporting other parts of the ultrastructure of the cell. And so, whether this is cause or effect, it remains to be seen. Liver studies have shown many different findings, and this includes acute hepatitis to congestion to steatosis, lymphocytic infiltrates, even some fibrosis and some central vein thrombosis. But to be honest with you, if truly the COVID-19 sequelae are very acute, then many of those features that are being described in the liver may not be due to the fact that this is COVID-19 infection at all. In fact, that it could be due to patients' comorbidities and previous past medical history. Some newer articles that have recently come out here, this article by Ackerman et al. Talks about pulmonary vascular endotheliitis, thrombosis, and even angiogenesis in SARS-CoV-2 that is kind of, almost like an intussusceptive angiogenesis within the cell. There are also studies now that have started looking at FFPE samples. And so this is formalin fixed paraffin embedded tissues. And you can now the Sigulek and colleagues have published the fact that you can actually do a molecular detection from those samples that have already been fixed in formalin, and you can kind of look at the RNA. The viral RNA has been shown to be present significantly in the lungs, the bronchial tissue, lymph nodes, and spleen. And this has been done by reverse transcriptase quantitative PCR analysis on FFPE tissue. However, there were lower levels in the liver, and no viral particles have been recovered in the study in the kidney. Lastly, the SARS-CoV-2 has been detected by immunohistochemistry. Like I showed one image of the pneumocytes being infected, and that was in situ hybridization. But immunohistochemical studies have also been showing SARS-CoV-2 and how it has specifically been looking at the extracellularly. It's been seen amongst the cilia and also within the cytoplasm. It has been seen in the lungs by immunohistochemistry and also by electron microscopy, but it has not been seen in the heart, the liver, or the kidney. This was basically published in the Pathology and Pathogenesis of SARS-CoV-2 associated with fatal coronavirus disease. So I've already mentioned that there is a need for negative pressure rooms, and not all centers are performing COVID-19 autopsies, but many centers actually are. And those are the centers, and I kudos to Dr. Mukhopadhyay and his team, who's been looking at all sorts of different manifestations of this disease and kind of really unraveling the mystery of what it does as far as pathologic mechanisms is concerned. However, if you are obviously suspecting a patient, then, beyond the RNA PCR, the nasopharyngeal swab, which I'm assuming that every single person who's listening, who's a physician or clinician who's listening to this study, this talk, will probably have access to. You also have to remember that there's supply chain issues. This is something that, in the last few minutes here, I wanted to talk about. There are numerous situations where you can have the test in place, you can have the validation in place, you can have the personnel in place, you can have the positive and negative controls, the swabs, etc. But sometimes, you're out of the plastics that are responsible for part of the testing. Just the supply chain in the whole country right now is under extreme pressure because we are, using the materials and all of the tubes and the test doing reagents much faster than many things can actually be produced. And so in many cases, there is a significant amount of frustration that the laboratories are not performing the tests as fast or as quickly, or the turnaround time is not very good. And you have to be cognizant of the fact that it might not be because the test isn't running properly or whatever. It's because we are literally limited in the amount of material that we have. And there are obviously numerous calls across the country to make sure that those supply chain and demand issues are solved. But it's important to remember that this test cannot just be run in someone's research lab. I mean, there are some conditions where you can screen with an emergency use authorization, but ultimately for clinically actionable results, you have to use a CLIA certified laboratory. And, and in those, we are currently facing a significant number of issues of supply chain. So in the meanwhile, the pathologic manifestations, which we were talking about today, range from the same lymphopenia, to just summarize, the neutrophil lymphocyte ratio, the ARDS, which is manifested as diffuse alveolar damage, bronchopneumonia, and pulmonary vascular congestion. Thrombi are becoming a big problem, but now we can study this virus by both immunohistochemistry, by in situ hybridization, and also in formalin fixed paraffin embedded tissues. And so we're really coming closer to understanding how badly this disease obviously ravages our body. And that was it for my slides. I will hand it back over to our hosts, who can guide us with any questions.
Hey, thank you so much, Dr. Mirza. That was a very good talk. And I always say that it's really important to understand the pathologic manifestation of any disease in order to really comprehend what's going on. I think I have a question about the thrombosis aspect. So to me, this disease is still like mainly a pulmonary disease, but it does affect other organs. I noticed that there's a surge of microthrombus, especially in the capillaries and other places in the lungs. So I think the challenge we have is that sometimes when you test for thrombosis, like you test for DVT and PE, and the test will be negative, but that surge of microthrombosis is there, it's just that we cannot catch it in those imaging. So
Right.
I think the big discussion, and I think Wally probably on the other side, because I just saw that he posted a statement about about a study, is that right now different facilities are doing therapeutic anticoagulations and others are doing just prophylactic. So some places they do the test, they rule out VTE, and if VTE is absent, they continue with prophylactic anticoagulation. But one of the slides, it seems like some patients, even though they're negative for VTE imaging, they still have that surge of microthrombi, and that can lead to death and to increased mortality. So what do you think about that from a pathological standpoint, from the slides, from the different pathology that we see?
So absolutely. I mean, I obviously can't speak towards whether there should be prophylactic treatment or not. However, the just a pinch of salt is that the images are from the fatal cases naturally, right? And so the fatalities that are occurring are happening in like the worst infected patients, and in those you definitely can see microthrombi. However, if you look at the studies that I showed, they're not all cases with microthrombi, right? I mean, there's some studies which have them, and then some which don't. We only report them in a subset of patients, and these are all autopsy studies, so these are all patients who died of the disease. And so it doesn't, so I can, we can postulate that it could be because of vascular dysfunction. Could it be because, let's say in the capillaries, when there is destruction of the pneumocyte or like, that type of infection, it also affects the endothelium or the basement membrane, and that causes the nidus for the microthrombus. But to be honest with you, it's variable. Even within the autopsy studies, we don't see it across the board. So it's one of the main features, definitely. But it's just like you're saying, it's like a lung-based disease, but in many ways, it's also being shown now to be a vascular disease. But whether it is worse in a patient's vessels or worse in a patient's alveoli, it's kind of difficult to predict.
All right. Well, Cameron, thank you so much for that informative talk, and I've certainly learned a lot, from this last hour. So let me field Team Walbridge's question here on Facebook.
Sure.
He wants you to talk a little bit more about memory and brain. So, and what's your take on, all these neurologic symptoms that people are presenting with, and then they turn out to be positive for COVID. So I think that's what Tim is alluding to.
Yeah, Tim, to be honest with you, I don't know. I just knew it anecdotally because of discussions that I've had at home. But there are definitely cases now that we're hearing about where people, are forgetting like very day-to-day kind of items or like what they had for lunch, and they're bewildered. I mean, they've recovered from COVID. They don't have any pulmonary sequelae. In general, they're doing fine, but there are cases where all of a sudden it seems as if there is some sort of organ, not dysfunction, maybe it's transient. I have no idea. This is just all very speculative, nothing scientific. It's just based on anecdotes. There, for example, I have a friend, a very close friend of mine who had the disease. He is overseas, not in America, but he recovered from it. He quarantined, recovered, and now he has insomnia. He just can't sleep. It's just one of the things that he can't attribute it to anything else. He's never had a problem. He's my age. With sleeping, but that's another feature. So unfortunately, I wish I could say something more intellectual about like the brain manifestations. I mean, there haven't been anything obviously specifically recorded in these autopsy studies, which would be very interesting, right? To see whether you can detect in the brain tissue, whether you can detect that there's direct evidence of the virus. But I guess that these studies, because they were done kind of trying to look at the acute causes of death, they didn't necessarily look at, well, although some IHC studies have looked at other organs, but they aren't necessarily looking at, the non-acute things. And so perhaps over time, when we get, more data from brains of these patients, we might be able to understand what's happening in a subset of them. But sorry, Tim, I really don't know much more about it.
All right. Thanks for that, Cameron. So in the same vein, I've seen a couple of diabetic patients come in DKA, even though they've been compliant and they all, at least many of them are tested positive for COVID, and they tend to be the younger ones, maybe even the diabetic type 1 patients. and some are presenting with acute pancreatitis. So I don't know, can you speak to that at all? Is there, any autopsy series or pathology evidence to suggest that maybe the virus is directly affecting the pancreas as an organ?
The only organs that that I at least looked at for this study were obviously like, in those that, I have them up here. I can show them to you. Like they were talking about which ones were most infected and which ones weren't. And so the kidneys and the heart and the liver have been studied. Nobody's really truly looked at the pancreas, to be honest with you.
Yeah.
And then there was this one other slide that I can't find it right now, but basically it was talking about the fact that the kidney was not as bad when you looked at IHC. But no, I can't recall any study specifically talking about the pancreas, but it would be very interesting to look at. So the pancreas and the brain both.
Okay, gotcha. And speaking of the kidney, any evidence at all of actual virus causing problems in that regard?
Yeah, no. So I showed you the electron microscopy of what we thought were viral particles, but also, like, actually Dr. Mukhopadhyay had found out that there were some studies which were showing electron microscopy evidence of this being a virus. But actually, then there was a dispute between specialists looking at ultrastructure that those could just be Golgi bodies, and so you're looking at a very tiny thing. And even with electron microscopy, how can you, with the presence of something like on image, like, on histopathologic imaging doesn't necessarily indicate for sure that there's infection, or the reason for the organ dysfunction is because of the presence of that thing. So the IHC study didn't show much in the kidney at all, but the electron microscopy did. So I think the jury is out whether the infection specifically is causing it, or is it just a result of the other types of sequelae.
All right. Thank you for that. So this one is coming from Kevin Berman. So the question here is, are you seeing platelet aggregates or just fibrin? And where is the fibrin deposit coming from?
So I think Kevin is talking about the microthrombi. So the microthrombi do have platelets in them, right? But they look like fibrin microthrombi. So the fibrin, when a clot forms, it's fibrin and the platelets together. But you can't necessarily see the particles of the platelet when you look at the thrombus. It's called a fibrin microthrombus. And so the platelets are definitely there. If you look at the peripheral blood films, they're not aggregating or clumping or anything like that. There's some changes, like I showed in the earlier part of the talk, where they're like some giant platelets with vacuolations. But again, that's a very non-specific finding. But the thrombi themselves do have platelets in them. Have people studied platelet dysfunction specifically? No. I would still wager that they're most likely because of endothelial dysfunction or epithelial dysfunction, that's actually happening with, the injury to the basement membrane being the cause of it. But, that doesn't explain the DVTs. And so, again, what's happening in one patient may not be the same as what's happening in another patient.
Got you. Thank you for that. And if I may just let everybody know, Cameron, you are a heme pathologist.
Yes.
So maybe you can comment on this. What do you think about the ABO group, blood group, and being a risk factor? There's been some talk about that. Do you want to comment on that?
So I'm not a transfusion medicine specialist, although I'm sure there might even be some transfusion medicine specialists listening. And so no, I have nothing intelligent to say about it. Of course, there have been some studies showing that your blood group typing can put you at a propensity for different types of sometimes even infections. But I'm not aware of that data, so I don't want to speculate at all.
Okay. All right. Well, that's fair enough. Mark, please go ahead.
Yeah, I have a question. There have been two different new hypotheses about some of the pathology of COVID-19. And one of it is about mast cell activation.
Okay.
And the second is serotonin toxicity. Do you see any case studies, any autopsy report that point out to any of these hypotheses?
So mast cell activation and serotonin kind of overactivity, these wouldn't be things that we could study at autopsy, right? So these would be functional assays, right? So functional assays you would only do when the patient is alive. Are there cases where we're seeing clusters of mast cells in organs? Not that I've read or have been reported. However, it is very likely or very possible that while the patient is alive, there could be some sort of a hyper kind of immune response, whether it would be mast cell related or serotonin release related, that is causing a further dysfunction. But I don't think that that relates directly into any type of material that we could study at autopsy.
And Cameron, so Tim had asked you a question about the brain,
which I didn't know.
So Tim wants me to press you. This is what he said, literally, press him a bit on nerve involvement. So do you have any take at all about cranial nerves involvement?
I wish I was an expert, Tim. I mean, I could open up Google right now and start searching with you. But to be honest with you, beyond that, you can pressure me. But unfortunately, I don't know. But you're right, though. It could be nervous, right? But we're not necessarily seeing. So it's not motor nerves, right? So I haven't heard any. So I'm trying to be sensible for Tim to try and give him an answer here. But basically, like, I don't think that the data has shown anything about nervous, like, motor nerve involvement, but in the non-motor nerves, to be honest with you, I don't know. It would be very interesting. I mean, again, this is very difficult to do, right? Because naturally, nobody's going to go around doing nerve biopsies in these patients, or brain biopsies for that matter. But it's definitely a very interesting thought, and probably it would be interesting to see if they made any comments about the brain. But I actually haven't read those in the reports.
I mean, we have seen many cases where patients that were affected before came back with stroke or neurological defect and stuff. And I don't know if you guys studied some of those reports. Do you have anything to say about that, like strokes and seems like they're more like embolic type of strokes. I mean, makes sense, but
I mean, again, if it's a thromboembolic, then it depends on how much the patient had actually recovered, or could it just be that there's stasis because the patient was immobilized for such a long time during therapy, right? This is your world much more than my world, right? So I'm obviously speculating.
Well, Cameron, maybe as more autopsy series come, out involving other organs, we may have to bring you back to talk about this, especially the brain.
I'd be happy, especially if there's an answer for the brain for Tim. I will come back just to talk to Tim about it.
That would be good. The kidney is kind of interesting too. I mean, the slide you showing the kidney is very interesting.
Yeah, absolutely.
I think that in general,
and the heart.
Again, if I was to guess, it would probably be all secondary, to be honest with you, rather than primary. I think that ultimately, like, I think what I came across at the end of this, researching this, the death is mainly because of pulmonary complications. And, I mean, it's like you said, you think of it as a lung disease, right? So I would think of it as a lung disease first, a vascular disease second, a brain disease, like really low down on the list.
And Cameron, Atul Bali wants to know, okay, maybe you can talk about the patterns of injury that you've noted in the kidneys.
So I'm not a renal pathologist at all, but the pattern of injury, the main pattern of injury, at least in the autopsy stage, were the microthrombi and the glomeruli. So acute tubular injury that you can see with tubular dysfunction, which you can see histologically, and then also the microthrombi within the glomeruli.
All right. So Cameron, maybe you can close with this. What is your take, in no particular order, what's your take on antibody testing, PCR testing, and saliva testing?
So they're all excellent tests if done in the right laboratories and if interpreted correctly. Right now, let's say if I was to get myself tested, I know that my hospital is now offering both antigen antibody testing, our department actually, and nasopharyngeal swab viral PCR testing. It all depends. If I'm symptomatic, I would probably still prefer the PCR test, which is nasopharyngeal. Hopefully, we can develop that for like a saliva tests too, because the nasopharyngeal swab isn't fun. But I think that if the PCR results are positive, then definitely believe it. The antigen antibody, for me, being asymptomatic right now, it will be great if I find out that I have antibodies to it, which means that somehow I recovered from it, because then I can go give plasma or something. I mean, but otherwise, other than actually being beneficial to some potential patients, I mean, it doesn't mean much. Also, because now the data is coming out that you can get reinfected, so it doesn't necessarily change anything other than the fact that if I have antibodies for 3 months, then maybe I'm protected against the disease. So will it change my day to day? Will I stop distancing or stop wearing a mask? Most likely not. Saliva testing is very interesting. It's definitely coming up, and it's coming up really fast. There's a lot of push on pathology departments to get saliva-based tests, especially if you can get a type of test that you can do quickly. What I have understood about saliva testing is that it's also PCR based, so it will take the same amount of time. It'll take a few hours after it gets to the lab. However, I'm associated with the university. Many universities are looking for a very quick kind of answer so that they can reopen the institutions. And now the Abbott test is coming out, right? Which it's claiming that it's got very high sensitivity, specificity, and it's like a very quick pregnancy test type of like point of care test with like 2 lines. So is that the answer? I think that the field keeps changing, but the government's definitely invested in that. So let's see. So I think that to answer your question, all of the tests have pros and cons, and I think you have to use them with that type of thing in mind.
Okay, and for our audience, do you have any other comments or suggestions at all?
No, just keep reading and keep the finger on. We all have to keep the finger on the pulse of where this is going.
Okay, and just sorry, I think a question might have just popped in. Let me see here. I think this is from Atul Bali. Do we know what antibodies confer protection from COVID-19?
So typically, when you think of antibodies, like the early ones are the IgMs, which typically aren't protective, but it's typically the IgGs. I'm just talking basic immunology here. So
Yeah.
it would probably be the IgG against the COVID-19. But again, the studies that have come out, which are, at least not the studies, but the one patient in China who's been reinfected, I at least am not aware of like what the antibody status was in that patient. And so I would assume that it's IgG antibodies, but how long lived they are, whether they confer protection against second infection, because we know that the virus mutates. So if it's a minor mutation, will it still give us the protection or not? It's difficult to say.
I think there's one report that came out today too. There's one patient in Nevada, actually in Reno, Nevada, that actually got reinfected also. So the report, the official report haven't been peer reviewed yet, but I think it's in the process of being peer reviewed to come out. So that'll be like 2 cases.
Infection to kind of consider how long after the sequel, it is. I always worry about the fact that, let's say that it's been if it's too close to the original infection and the nasopharyngeal swab wasn't done properly and you got one negative, but the patient was still positive, you never know, it has to be, I would say it has to be a certain amount of time after which their reinfection would, and especially since we know that the virus keeps shedding. So the virus keeps shedding for 2 weeks afterwards, but there's some studies that have shown that after 8 days, those viral particles are actually not necessarily infective anymore, right?
Yeah.
So the thing is that your PCR might be positive where you might not be infective anymore. And then let's say that one of the PCRs in between was messed up and then now all of it went negative and then all of a sudden it became positive again. I wouldn't necessarily call that reinfection, but if it's been a large amount of time in between when we know that subsequent, lots of PCRs were negative, and then after that the patient became positive. Yeah, so I haven't seen this Nevada study, the case yet.
I think this Nevada case, I think he was infected with mild disease in May. That's why they're reporting. And now in end of July, he got severe disease. So
that's a very interesting point, because many people have said that mild disease doesn't necessarily give you antibodies as much as a severe disease does. So it's possible that the mild, he was never immune in the first place. Again, this is all just hypothesis. I have no scientific backing for this, right? But people have shown that the worse the disease, the more severe the disease, the more robust the antibody is.
Right. I think the study that was published, the first one, the one from the patient in Hong Kong that actually became infected again, I believe we posted this on the Medical Journal Club Facebook page. It took 4 months. And then I think it was 4 months after the initial infection that the patient finally had viable virus again. But again, that's only one patient. So we'll see what happens as far as the timeline is concerned. And somebody does have a question about a timeline here. after you get infected, how long are you contagious? Do you have any thoughts about that, Cameron?
So I might not be able to quote the literature correctly, but I think that the 2-week quarantine makes sense because my understanding is that your PCR will be positive for 2 weeks, but I think after 10 days, the viral particles are not infective anymore. And so I think that there was a study done that looked at the viral particles after 10 days. And those viral particles did not induce infection, right? But they were still shedding, right? So the PCR is obviously a very strong, like very sensitive technique. It can pick up a small amount of RNA and then just cycle it up. So my understanding is that it's the 2-week quarantine I think is reasonable because most data, at least that I'm aware of, shows that after 14. So 14 days would probably be a good number. But again, I'm a pathologist, right? So I think that these people are asking the wrong person the questions.
Oh no, we absolutely value everyone's opinion, you know. So then thank you for that humility. So Cameron, this has been excellent. Thank you so much. We really appreciate this. You're welcome back anytime. If you are interested in the pathology of COVID-19 and other pathology related issues, you can find Cameron on Twitter, right, Cameron, at K Mirza, is that right?
Mirza, that's right.
Okay. All right. Thank you so much. We appreciate this. Yeah.